Good afternoon, ladies and gentlemen, and welcome to Panel 9, Workforce Development in Health, Training and Retention Strategies and Policies. I'm Sonia Argint. I'm the founder of doer.ro website. It's a solution journalism website, and I'm a former TV host for medical health program. And I'm really delighted and honored to moderate this insightful conversation about one of the most pressing challenges in healthcare today, the sustainability of our medical workforce. Let me tell you in the beginning that we are here offline in person, but we are also being watched online by over 150 people. So this is a conference that involves many interested parties. So let me introduce you a bit in the topic that we are discovering through the next 1 hour and a half. So across Europe, healthcare systems face unprecedented pressure, shortages of skilled professionals, increased mobility across borders, and rising expectations from patients. In this context, developing innovative training programs, implementing effective retention policies, and fostering cross-country collaboration have become essential pillars for resilient healthcare system. Our discussion today supports the EU4Health objective of creating a reserve of qualified healthcare professionals and ensuring that knowledge and expertise are shared efficiently across the European Union. We are joined today by 4 distinguished guest speakers for this panel, representing academia, clinical practice, and innovation in medical education. They will share today perspectives on how to prepare, empower, and retain healthcare professionals in an evolving and demanding landscape. And please allow me to introduce you our 4 speakers. So, on my right side is Dragos Păun, General Manager, EduSon Education, Associate Professor at Babeș-Bolyai University, a researcher and entrepreneur in finance and health economics. Dr. Păun's EduSon platform pioneers online professional education, blending academic rigor with corporate innovation. In my front is Dr. George Petrescu, MD, PhD, neurosurgeon at Bagdasar Arsani Clinical Hospital, lecturer at Carol Davila University. He coordinates the Extended Reality Lab in the Center for Innovation and eHealth, bringing immersive technology to medical education. Welcome. Again, on my right is Associate Professor Adina Turcu at the University of Medicine and Pharmacy of Craiova, Chair of Pharmacoeconomics and Pharmaceutical Management, Director of the Technological Transfer Center, and an international expert on health technology assessment and medication adherence. Welcome. And last but not least, in front of me, Dr. Raluca Tatar, MD, PhD, Senior Plastic Surgeon, Head of Plastic and Reconstructive Surgery at Grigore Alexandrescu Emergency Hospital for Children, a leader in pediatric reconstructive surgery, and academic mentor for young residents at Carol Davila University. So, each of the speakers will now share their insights through a presentation that they have prepared for you. Afterwards, we'll continue with a moderated discussion and take some questions from the audience. So please do prepare your questions for our speakers. So, please let me give the stage to Dragos Păun, who brings a vision of continuous learning in the digital era. We have a presentation, yes? Okay, so please. The stage is yours.
For the presentation to load, I hope it's here. I don't know if I should stand. Is it okay for the camera, or I should be right here? Okay, and I guess, is this working, or will you change the... Should work, right? Okay, good. So thank you very much for having us here. This is a wonderful conference. It's very difficult to speak in front of experts, but I thought I would make a short introduction on this topic. And we started from the idea, so to briefly introduce you to what we do. At EduSon, we teach doctors. We teach, let's say, continuous education. We do not give degrees, but we offer them training programs, especially in ultrasound. We have taught over 14,000 doctors. We have learned from the discussions with them. And in the last half a year, we have been involved in the training of all the family doctors that have received free ultrasound devices in this PNRR program that Romania implements. So we've seen a bit what are the positive issues and what the negative issues are. For instance, when we discussed with all of these family doctors who have received equipment worth of about 100,000 euros for free from the government, which is amazing, they have told us that they fear using these ultrasound devices because they have no practical experience. Having no practical experience, they fear in giving a diagnosis to patients. And also the fact that they don't know who to rely on if there is an issue. So we've seen more and more people talking about malpraxis and so on and so forth. So this is a very big issue that we as education providers and universities have to acknowledge. The fact that teaching has to change. Teaching has to come also in the third millennium. So we cannot teach how we were doing it 100 years ago. And if you could help me with the slides. And teaching is also linked with the retention of people. Because if we do not help our doctors, then our doctors will go away. And in our studies, we have seen that, first of all, we have outdated education models. I'm sorry to speak in front of academia about outdated models in medicine. It's not only in medicine, it's also in let's say, other topics. And I've seen a glimpse of Dr. Petrescu's presentation, and I think they are not outdated and they are moving towards the right directions. But outdated methods lead our young doctors to move to other countries because they see the gaps in our system. Then what we also have to acknowledge, I think, is the burnout and the administrative overload and also the stagnation in terms of doctors. Young doctors right now are overloaded with the work that they do and with especially paperwork, which is not in the benefit of doctors. We have talked to family doctors and we've seen that they have been transformed from the first step in solving medical problems into administrative, into secretaries. They give people directions to specialists, to hospitals, without actually giving them a diagnosis and a treatment. So this is a very big issue that we have discovered, and we can talk about the reasons for that. And then, of course, what we have to make doctors understand is that training is an asset, not an obligation. You have to train and you have to be trained to become a better doctor, not because it is a must, because you want to be the best, you want to become a better surgeon, you want to become a better doctor, you want to become a better healthcare professionals. So now the question is, how do we do that? How do we do that? Because if we offer the best quality to our doctors, they will stay. If we offer the best equipment, they will stay with us in Romania. So here I've written down this is a bit of an introduction, how we see things, how we think. So we see a need for experimental and contextual and, of course, modern medical education. And what is modern medical education? So for instance, it is experiential learning. It is immersing doctors into actual real-life scenarios. Of course, they are doing this a lot of times, but this has to move on and on through the entire lifespan of their career. You must put them in actual situations and not just document, because right now theory is all over the place. They can learn theory from YouTube, they can learn theory from TikTok, hopefully not, but they do take that as a source. But that is not right. You need to have a certification of the quality of the information. And if we do not understand this, then we have an issue. If we do not provide them with a fast alternative to this TikTokization of learning, if we do not feel this, if we do not understand this, we will lose them, because they will move to what is easiest for them. To learn from TikTok, to learn from ChatGPT, to learn from Gemini. But all of these AI tools, they give you the answers that you want. They do not give you the answers that you need. They talk to you in a sense that you are not mad at them, because if you are mad at them, you'll not carry on the subscription. But the professor, he wants you to be mad at him, because he's telling you what you need to learn. Sometimes you don't like that. So we see this experiential learning as, let's say, as a must. We also have seen that you need a bit of contextual training, meaning you need to adapt education to specific clinical environments to prepare healthcare professionals to diverse healthcare settings. We cannot teach them in a bubble. And then when they come out and see that actually real-life scenarios are different, expect them to master everything. So that is also an issue. And then, of course, what is easy if you have this new way of teaching, it is giving feedback, instant feedback, because you have somebody supervising you. So that is, I think, really important, because if we don't have an immediate feedback, then you cannot learn. But we are afraid of this. We are afraid of acknowledging, and nobody wants to be told that they are wrong. But this is something that is happening. We don't like to be told. We have seen circumstances where the professor cannot be wrong. And I'm sorry, we are here again with members of the academia, but this is a very big issue. I'm addressing issues that maybe somebody will say he's stupid addressing these issues. I acknowledge, I'm a bit different, also in my faculty and also in what we do. The professor can be wrong. I've heard a professor from Cluj, when we went to talk to her, and it made my heart grow. She said, I'm okay with somebody telling me what to do if I go in the ER, because that is not my specialty. We were talking about a serious case, and she said, the era where the professor knows everything is gone. I am a specialist in my field. If I want to have a surgery in another, let's say, in another pathology that I'm not familiar with, I can get the help from even a resident, if the resident is a specialist in that field. So I think this is also very good, and I think this is where we should tend to lead. Now, how we are doing this with our company, we are doing clinical simulations. We have organized the biggest, let's say, biggest mock hospitals, for instance, in Constanța during this summer, where we treated about 160 patients, where they came to get ultrasounds. We did a screening for different diseases. We want to do that. We want to have our learners experience not only mocks and students that are in perfect health, but also people that are coming from the street and are in need of medical advice. So we put our learners in these conditions where they need to talk to the people, to real people. They need to address the issues that they face, but of course in a supervised method, like you see here, where we had Professor Wortsman, who is the leading expert in dermatologic ultrasound in the world, showing our learners how to do this. So I think this is the way forward. You need experts showing you, but you need to put doctors in real life scenarios. And this is what we have been doing for the last 4 years. We are an online medical platform, so we are also broadcasting everything. However, we know that there are 4 elements to being a better doctor. You need theory, you need guides, you need procedures, you need to see an expert how he's doing, and last, that is the cherry on top, you need a community to rely on. And I think this is very good, to know what to do if you are overwhelmed. You need to send them to the expert. And I think I also have a last slide. What would be this impact of practical training? Of course, we have accelerated skill development. And then, of course, we have the boost in professional confidence, because you see that actually you're helping people. You see that you're helping people, and then you have this improved motivation and satisfaction when a patient walks away from you, even in our training programs, and they say, "Thank you very much. It is the first time that I had an ultrasound. It is the first time I know how to solve this issue." And unfortunately, even in these training programs, we found different cancers in different stages. And of course, we always go with, let's say, we go somehow concerned into this, because we don't want to find these issues. But sometimes we ask ourselves, is it better if I know that I am sick and then get as fast as I can medical treatment, or is it better to live without knowing? I think this is an ethical discussion, and everybody is different. We believe that the faster you find out that you have something, the faster you can be treated, and the better it is. So this is why I encourage, and these were some just and a bit of an introduction, and I think it's very good that I was the first to speak. I don't want to get deep into it. I know that our esteemed colleagues from the universities have these programs, and they want to share with you what they do. And we have here top universities in Romania, and of course we know that in quality of education, the universities in Romania are top. And this is why we have more and more foreign students coming, and I thank them for being great. But there is, let's say, 5% more that I think every one of us can do. I hope I didn't take too much time. We can talk more if you want on this subject in the free discussions.
I would like also to address you a question right now, because you have started your presentation by saying that technology is amazing for young doctors and for doctors in general, but they are afraid of using this technology due to the lack of knowledge in putting a diagnosis. And you've also came up with this example of your presence in a certain place and gathering patients as well as doctors to see how it works. But how can you make this scalable? And who should be in charge of growing this kind of interaction and training?
We are trying to do that on our own. I think it's not just one company that can do that. I can tell you from our experience, last week we were in Călăraș, 2 weeks ago we were in Bucharest, we were in Constanța, we went to Craiova, we went to Cluj, of course, a lot of times, Baia Mare, Iași. So we are doing this. Of course, we need also, we need people to understand that this is an issue, and we need to I think we need to involve more people, and maybe the College of Doctors into these practical programs. I understand that, and we have a online medical education platform, so to say that online is bad, I think I would throw my business out the window. But there are good and bad things with digitalization. Digitalization and online learning I think, has helped people to get access to resources. However, we cannot rely only on digital. Would you trust a driver that has learned to drive playing Grand Theft Auto?
Of course not.
Or would you like them to also have 2 hours of actual driving experience?
Maybe more than 2 hours.
Maybe more than 2 hours. So I think we need to have a balance, and universities are doing that. But it's difficult to say. In the university system, we are used to receiving money per student. And I think this is the worst thing to have. Money per student makes us want more students, and more students. And what do we do when these students graduate? We have 300 graduates of theology every year. Can we have 300 churches for them? Impossible. We have, I think, more than 1,000 graduates of the universities of medicine. We should have places for them in our hospitals. but do we
should,
have?
and it's actually necessary if we think that by
This is why I say
2030 the EU
we should.
will have a lack of 4 million experts in health,
That's true.
health workers.
Unfortunately, this is the reality. It should change. I don't know who should change it. Maybe the government, maybe the universities, because they feel the same pressure. I don't think we are God to have answers to everything.
Dragos Paun, thank you so much for your
Thank you also.
presentation. And please do not forget that at the end of our discussions, you will have the opportunity to address your questions to our speakers. So, moving forward from digital learning to immersive training, Dr. George Petrescu is at the forefront of extended reality in medicine. I will ask you, Dr. Petrescu, to tell us how can these technologies redefine the way young doctors are trained?
Yes, of course, and I hope I will try to my presentation to explain how this can be achieved and how we can improve the medical care by using these new immersive technologies.
Thank you.
Thank you for the opportunity to present our experience with extended reality. Are the slides? I have to say I have no commercial disclosures related to this presentation. I'm going to go a bit into the introduction to explain a bit about the extended reality. They are different. This is a one big umbrella that covers a few topics. So when we talk about virtual reality, we will talk about 3D models that are exclusively seen in a virtual reality environment. So for example, as you can see in this image here, we are going to have a medical student or a resident in training using a specific headset where he can be immersed into an operating room, for example, and then he can see the patient and go to the steps of the surgical procedure. There are other types of extended reality, such as the augmented reality, where we will superimpose a 3D model in real life. And when we combine these superimposed models and when we can manipulate them by using different instruments, for example, in the surgical operating room, then we will talk about mixed reality. I'm going to focus a bit on the educational role of these technologies, and then I will discuss a bit of the clinical applications. So from an educational point of view, we all know that designing a new curriculum, developing new teaching tools, training the faculty, these are all very time-consuming and expensive efforts. And it is important to take into account the fact that these new technologies exist, then that we need new methods to attract our students. So this is one of the reasons for why we are using these technologies. Of course, there are a few other disadvantages of the traditional learning methods in the medical field. Sometimes you would have a limited accessibility or a high cost, or as my predecessor speaker said, there might be outdated information, so we will need other methods. Of course, there is a limited clinical exposure that can sometimes be overcome by using new methods that would allow to rehearse a particular case that maybe is a rare pathology. So coming to the purpose of training models, they can be very helpful in learning complex notions, but of course for surgical specialists, for example, or even medical doctors that do certain procedures, it is very important to have developed motor skills. So these simulators can be used to refine motor skills, and of course to practice difficult approaches. Why virtual reality is a good method for this? Because it's a very deformable one. You can manipulate the 3D model in whatever reason or whatever way you want, and this allows you to perform a surgical intervention or a medical one in multiple times. You can have a haptic feedback. And this is one of the reasons for which in the past years there is an increased number of papers in the literature about the use of surgical VR simulators, as well as more and more experimental studies that use the virtual reality or other XR methods. There are a few papers published about this as well. This is a systematic review about the training in neurosurgery. Of course, I'm not going to go into detail without all of this, but what I wanted to point out is that a lot of these new papers and new technologies for training use virtual reality. As you can see here, they are highlighted. Just to give you a brief example, this is a method of aneurysm clipping. Aneurysms are dilatations that can occur even in the intracranial arteries, and these can have devastating consequences. So it is important to have people trained specifically to address this. They can be endovascularly addressed or through surgical intervention, especially in the rupture cases. So you will need more and more people to train, especially for these difficult cases, especially in the area of endovascular treatment, when you will get less practical experience in the surgery with these cases. So for these examples, like a middle cerebral artery aneurysm, you can see that the cases that were performed intraoperative had a pre-op reconstruction, and you can see with high fidelity the vessels here and the simulation to clip this aneurysm and exclude it out of the circulation. And this can happen, of course, for other aneurysms as well. Other field that can be used is the spinal surgery. Neurosurgeons, orthopedic surgeons can visualize these models and, for example, train and plan how to put in screws to stabilize the spinal column. I believe my colleagues will present also, I believe in the next days of the event, a few of the applications from the 3D printing lab for this as well. And we can see that there are a number of studies that show that there is an increase in the skills of trainees that use virtual reality methods, for example, for temporal bone dissection. So using this method gives more confidence to the trainees and more skills when they are to perform this procedure. So what we've did at Carol Davila University of Medicine and Pharmacy at our Center of Innovation and eHealth, we've established, I believe, 3 or 4 years ago, a virtual reality lab, the extended reality lab that it's now called, where we started doing workshops for medical students and medical residents in order to teach them more complex notions, for example, neuroanatomy. And we started small with a few headsets, but a very large number of students that were very enthusiastic to participate at these trainings. So this is one of the reasons why we have continuously expanded our laboratory over the past few years. And what we can also do with this method regarding the reach, we can also have specific workshops. As you can see here, these are some of our residents at Baghdad Cerny Hospital and some of the medical students that are really passionate about neurosurgery. And here we are connected online with colleagues from University Hospital in Sofia in Bulgaria. And we have lectures on both our side and their side, and our residents and theirs are connected in a virtual environment through VR headsets. And there is like a museum where you have different 3D models of complex brain anatomy. So each one of us can get that model. You can present it in front of the others and talk about very specific neuroanatomy notions. And we try to gather this data, and we've seen that there is a very good evaluation from the students regarding the practical part of this VR experience, having a high median score. And more often what we do is we do a test before this, and also we test them after they went through to an VR experience, and we've seen that there is an increase in the number of correct questions that the students can answer after they went through such a procedure. Of course, there are other simulators that can be used. This is one of the basic models that was done in partnership with our technical colleagues. For example, a lumbar puncture simulator for medical students that they could practice and see exactly each specific structure to which the needle for lumbar puncture goes before doing the procedure on a more advanced simulator and laterwards on a patient. Besides the role for patients, there is for medical doctors, there is also a role for educating patients. And there are more and more studies that show an increase of using virtual reality for training patients, especially when it comes to explaining them about the pathology that they're having. So there are a few studies now that show that when you use virtual reality methods or any method of extended reality, when taking the informed consent, you will also have an increased level of confidence from the patient. They will also learn more easily about the possible complications that can arise, and those also the level of anxiety will be more reduced. And of course, there are more other studies on this topic. For example, even the residents believe that it's more comfortable for them to talk with the patients and discuss about the pathology when they are using these technologies. In the last minutes available, I'm going to present you some clinical applications. Extended reality techniques can be used for preoperative planning, for example, of these breast tumor cases. Basically, you will need a very good quality CT or MRI scan that will be laterwards reconstructed with different AI technologies as well. This is another case of complex oncological procedures in the gastrointestinal area, lung metastases, that here you can also see the relationship between different hepatic arteries and the tumors. You can even approach for these large retroperitoneal paraganglioma, you can perform a perfect simulation to see the neighboring structures. For lung tumors, you can perform a high-fidelity segmentation from very good quality images, and you can see in the virtual environment the tumor and its relationship with the surrounding structures. And of course, there are a few other applications in neurosurgery that I'm more familiar with, and there are a few papers published, for example, for skull-base meningiomas, a very complex surgical intervention because there are a lot of neighboring important structures, vascular and cranial nerves there, and you can see them in the virtual environment, and then with augmented reality glasses, you can better study these structures and therefore use your approach. And we do this in our clinical practice as well. For example, for this large pontine cavernoma in a relatively young female patient that presented with a rupture, bleeding at the level of that lesion. We have our residents train for this and learn about the case. So you can see here a model of the brainstem with all the tracts, their cranial nerves, arteries, and all the safe corridors that these lesions can be approached to, therefore making the surgery safe for the patient, and therefore being able to resect this completely and have a good postoperative MRI with a good functional outcome for the patient. And we do this even for more complex procedures. This is a case of a young female as well with a very large arteriovenous malformations. These are very large abnormal vessels that can arise at the level of the brain parenchyma, and they can endanger the patient. They can bleed very easily, and by this, then the patient will have deficits or can even die from such a bleeding. And we use these 3D models in order to better visualize which are the vessels, the arteries that feed this, and the vessels that will drain the lesion. And this is very important because otherwise in the operating room, you might have something that looks like this. So it's important to train ahead and plan in order to be able to understand which vessel is which and what do you have to resect there. I'm going just briefly to talk about the medical rehabilitation. There are a few studies that show that extended reality techniques can be used in order to improve the functional outcome of patients after stroke, for example. And this is just a method from an American company that uses this. For example, you would like to gamify the experience of rehabilitation by making some more interactive exercises so that patients will be more adherent and more compliant to performing rehabilitation. So in conclusion, I believe extended reality can be very helpful for medical students and residents to learn very complex notions, such as one of them is neuroanatomic, for example. It can be also an educational tool for our patients and will allow us to better explain the patients how we are going to address their pathology, and can also, of course, be used as a rehabilitation method. It can be used for procedures, for example, under local anesthesia as well. Thank you.
Thank you, Dr. Petrescu. It's a very promising future, let's say, for the health and for the precision of interventions on patients. And I'm very curious to know how long does this training last until the professionals can actually apply technology in real surgeries. And
so I believe when we talk about this technology in the educational field, there are a few different components. For example, it's the educational part that I presented, where you would have one of the trainees use this. I would not say that this will come as a different approach to medical education, so it will not be used instead of the traditional methods, but it will use complementary, so we will add this in order to have them more easily understand that very complex notions. And we've seen from our from our neurosurgery residents that they say it's a lot more easier for them to learn such complex anatomical structures. So this is one thing that will, of course, shorten their time needed to understand some very complex notions. Regarding to the clinical application, of course, there is also the learning curve that is needed to actually learn how to operate this, but this is something that, of course, with a few sessions, it's easily done. And for younger generation, it's that played video games, for example. We have young trainees that really...
It's more intuitive, probably, for them.
Yeah, it's very intuitive for them.
And I would have also another question. How do you ensure that these technologies remain accessible and not limited to, let's say, elite institutions?
So, for example, these, the main concern is about having these models and having access to license, for example, for software that can reconstruct these models. But I believe once you have a library of models, of cases that you will have created, then the headsets nowadays are more and more cheaper, and we have now even vendors that are collaborating with different machines that we use in our operating room in order to integrate VR as well into this. So I believe it's going to be more and more easy to have in medical practice.
Thank you so much.
Thank you.
Now, let's turn toward policy and international cooperation, areas where Associate Professor Adina Turcu has extensive expertise. Professor, I would like to ask you, how can Romania align with global standards in professional education and assessment? And of course, to give us your presentation.
Thank you for your invitation. From VR, I move on statistics. A lot of statistics in health economics or pharmacoeconomics experts. May I have my presentation? So there are few health economics or pharmacoeconomics experts in Romania, and there are in the last time a lot of masters that proposed to gain this expertise, but I want to show you more where we can apply this pharmacoeconomics. Their role is very important in the reimbursement systems. So if you want a new drug or a new medical device or a new medical service or pharmaceutical service to be reimbursed in the Romanian medical system, you need to pass through these evaluations. So these health economics experts must provide a lot of evidence that could be a great help for decision makers, that could be HTA body or payers. For example, in Romania, National Agency of Drugs and Medical Devices has an HTA department that established if a new drug is will be part of C list or A list or B list in reimbursement system. So HTA, that means health technology assessment, is in a continuous changing because a lot of data, we need a lot of data, and also a lot of advanced treatment appears, but the money are the same. So this health technology assessment is part of all health systems. United States of America was the first country that proposed this type of assessment, and European agencies, including Romanian agency, applied this system. So we need these experts. They are part of a team that includes, of course, different type of experts from doctors, pharmacists, a lot of statisticians, and they play an essential multi-phased role in the drug and health technology reimbursement process. So they provide a lot of evidences that help decision makers to determine if a new technology offers value for money. So this year was the first year a master appeared at the University of Medicine and Pharmacy Iuliu Hațegaну in Cluj-Napoca. Even if I am from Craiova, I teach in this university, so I know very well what they offer. This master is an original one because they propose theory, a lot of theory, but combined with people that has a lot of experience. So if you want to become expert in pharmacoeconomics or in health economics, such a master could be a good choice. It is a hybrid model, this model supports working professionals. So the courses and the seminars are also online, but we recommend to do practical things in the university. And I encourage you to see what it offers, because a lot of experts, also international professionals from international universities teach at this master. So what is HEOR? It's health outcomes, health economics and outcomes research. The lectures are in different directions. The students will have the ability to evaluate clinical and economic evidence. So there is a lot of health policy and a lot of statistics in this direction. You will need basic skills in statistical analysis, but you will become a better statistician through the lectures you will do there. Of course, there are a lot of other lectures that appears in the last years, because if the law started from 2040 to include a score that is calculated based on other countries' experience, Romanian HTA will be changed soon. We will have a new law next year, and we will assess the new drugs, the new medical devices using this law. I don't say the last regulation was bad, because we do have a lot of new medicines in Romania, but a lot of more other advanced therapies are discovered, and we need them for our patients in Romania also. In this moment, this HDA scorecard is calculated based on France experience, based on UK experience, and Germany experience. This means if they have this drug in their countries being reimbursed, in the moment the industry came with these drugs in Romania, they obtain a better score, a better, I don't know, 30 points for being reimbursed in France, or 10 points being reimbursed in UK. So this will be history, and the next law proposed a better cost-effectiveness analysis based not only on clinical trials that was performed for that drug, but also for how big are the benefits that drug will propose for the patients. So the quality of life is very important in this health technology assessment, and it will be analyzed through other studies. So because new data, we need more data to be analyzed, and because advanced technology needs different statistical analysis, we are trying to use artificial intelligence even in this domain. So my presentation for today was not only to be an awareness for these experts that maybe are not very well known, but also to see how artificial intelligence could be used in this domain, because we are afraid, most of us, not including me, about using artificial intelligence. Many people said that they will be, I don't know, artificial intelligence will be used in place of them. So I think a lot of discussions were taking place based on this subject. So my presentation wanted to show that artificial intelligence is a big help even in this domain, even if it was not used, still used. I was searching, of course, what in international research was done. We collaborate with international societies. The best is ISPOR, the International Society of Pharmacoeconomics and Outcome Research. And from them, we take all the methods and all the methodology they use in better choose reimbursed drug in their countries. So they proposed, of course, real-world evidence. They propose better drug pricing, and on third place, using AI and advanced analytics in healthcare. Where do you find these experts? So can they be replaced by artificial intelligence? The stakeholders in health economics outcome research are regulators, payers, providers. So you could find them in health authorities and ministries, in pharma industry, in health insurance organizations, regulatory agencies, research institutes and universities, and in international health organizations. So I think in this conference we could find some of the representatives from the last slide. What is rising to the top right now? As we saw in the last slide, we need better real-world evidence. And if we are in Union Europe, we could choose to use joint clinical assessment. I don't know how many of you are, I don't know, interested in this domain, but I'm sure all of us need drugs. And if we need a drug, and it is a drug in, I don't know, cancer or in rare disease, so a drug that was discovered in the last years, that drug will come in Romania only if it is health technology assessed. So in the last year, a joint clinical assessment was applied, and till 2025, we can apply this joint clinical assessment for all new drugs. Right now, we apply it only for rare disease and cancer diseases. So, the power of artificial intelligence. Can AI transform reimbursement decisions? There are a few research in these directions. I do a lot of pharmacoeconomics research, and because time is precious for me, I use artificial intelligence wherever I can. So I've tried to find tools that promises saving time. And for doing a meta-analysis or for doing a systematic review, we use, of course, some softwares that are recognized by the guidelines. And in these directions, I've tried to verify if Cochrane or Ryan that promised including artificial intelligence was real promising or not. And I found that their promises were not real. So in many places we can find, yes, we use artificial intelligence, yes, we are better because we included this in our tools, but in some cases they didn't succeed. I don't say they will not, but they didn't succeed. So I use the same classical tools and in the same way. Even if regulations tried to include a lot of methods that can use artificial intelligence. So these are the main stops in pharmacoeconomic analysis, and the last one, cost-effectiveness evidence. Of course, we use a lot of data. Of course, artificial intelligence could be useful, but it's not in this moment. So a lot of regulations appears. The last one, and I've put it on this slide, came from California, United States. In September, they published a Transparency in Frontier Artificial Intelligence Act That is an example for regulation. It's very important to have this transparency because, as we talked about malpractice, we can't say AI made that bad things. So the doctor or the person that uses artificial intelligence will be the person that made malpractice, so not AI. This is why we need to validate all the results we used in AI analysis, and the transparency is also very important to know how they use it, when, and in what manner. So thank you for attention. We could talk more. I like this, I don't know, informal way in this conference. So
thank you,
I
Professor
wait for the questions.
Thank you. This is a quite difficult subject for a non-expert.
Yes, I didn't know how to to direct the discussions.
But it's okay because we have experts with us here and online, and for sure in the second part of our panel we will have their questions to you regarding the topic.
Okay.
Thank you.
Thank you.
So, finally, we move from policy to practice. Dr. Raluca Tatar leads by example in one of the most demanding hospital environments. Dr. Tatar, please join us here on stage. And I will kindly ask you to talk about the challenges that you face in your hospital with retaining medical workforce, and what are the challenges that they face and that you face as well, and what might be solutions.
Well, I am leading the oldest clinic of plastic and reconstructive surgery and burns for children in Romania, a clinic that was started by Professor Enescu 38 years ago. And I have the chance of working in a very special environment where we really function as a team and as friends. So my examples and my talk won't be an illustration of what we experience, but of what may happen and what happens generally in the healthcare system in Romania and anywhere else in the world. My colleagues in the first two presentations punctually mentioned the word burnout because it is an issue, and we must, before talking about this, we must remember why we start, and when I say we, I say we physicians, why we started and why we chose this way in the first place. It was about helping people, about trying to make their lives better, trying to cure some diseases, trying to improve some conditions, because we are really aware that we cannot cure everything, even though we maybe as young students we dream of actually curing. It's more about offering a good life to our patients. So we must remember this is what we wanted to do, what we dreamed of doing. And some way on the road, some of us are losing these directions. Maybe the Romanian participants remember that this summer we had the news of 2 young residents in Iași who were found dead in their apartment. And we didn't really know the cause, but probably burnout was a competing factor in this. So it's quite a while since the well-being of healthcare staff has been identified as an area of concern. They experience an increasing and under-reported and under-acknowledged, even by themselves, level of stress, anxiety, and depression. This leads to emotional exhaustion, cynicism, depersonalization, with reduced professional efficacy and personal accomplishment. And the effects of this are on multiple levels. On the personal level, physical and emotional. It has consequences on our patients that do not benefit from the best of our capacities. And they start developing mistrust in the healthcare professional group. It has consequences on the healthcare system with the problem of retaining the staff in the system, and consequences on the community and the society as a whole. Defining the problem, it's also a challenge because many healthcare professionals have the tendency of considering this a personal issue, a personal coping issue. And it shouldn't be like that, because actually burnout for healthcare professionals is more an occupational phenomenon and not a personal incapacity of coping and adapting to challenges. And recent publications have actually shown this. And some of us do not manage to get out of the problem. And one of the main causes of suicidal doctors is the fact that searching for professional support from our colleagues, psychiatrists, is sometimes seen as a stigma. They face problems when coming back to work because they search for psychiatric support. So they're trying to resolve the problem by themselves, and sometimes, when not succeeding with it, they decide to end their lives. This slide is made from different images from a campaign in the United States 2 years ago that combined a public support for healthcare professionals with arts, and it was called The Disposables. And why the disposables? Because doctors cannot be disposables, but these portraits made as an homage to those that were gone, those portraits were made by disposable material used in healthcare environment, like gloves, vials, tubes, and so on. So they use something that is disposable to make something that may last in order to draw attention on this issue. And I really liked their logo. It's time to heal our healers. So many things in healthcare are designed to be disposables. Our doctors cannot be one of them. Because, as the first speaker mentioned, okay, we may have a lot of devices. We may have a lot of investments, but if we don't have the people knowing to use them, we cannot have medicine, we cannot help diagnose and cure people. So our doctors are not disposables. How can we solve this problem? First step is the public acknowledgement that this situation actually exists. We have to identify specific therapies, and we really should focus very much on prevention strategies. And prevention has to be directed in two different spaces. First, at the organizational level, and this is where I said I am fortunate and privileged, but creating a healthy environment where people have chance to feel appreciated, where the members of a team have time to debrief about difficult cases. that meant a lot of burden for them. Where there is this spirit of a team and a friendship, lowers the risk for burnout. And the other side, it's on the personal level, and we will see something about that later on. Secondary strategies that would help individuals to cope more efficiently with challenges like social support, peer support, self-appreciation, and self-care. Tertiary initiatives focus on the treatment for individuals that actually got into burnout and help them be back on their best physical and emotional situation. And moving from general to personal, one of the problems is especially for young people, and the ones involved in teaching may have noticed that in recent years, medical students have this tendency to be very competitive, and not to make friendships with their colleagues during student years. And the idea and the concentration on acquiring skills and knowledge, which is very good, makes them forget that there is life also apart from medicine in this world. So making the work as the most important feature of their life, making it a substitute for social life, is a very dangerous attitude, and intervention at personal level should focus on this issue. One possible option is using arts. Arts that has been defined by the World Health Organization after a huge review of the literature that included 3,000 studies as a benefit for well-being support in any kind of people, regular people, healthy people, normal people. So with more reason, it could be help for the patients, but for the healthcare professionals as well. This summer in Italy, there was a convention organized by their Ministry of Culture that was titled Prescription of the Art That Heals. And there are in other places patients that get prescriptions of visiting museums because this situation helps them, especially for mental illnesses, get a balance and cope more easily with their medical problem. Art inserted in the hospital environment. We need our places of silence between two difficult cases, like a garden or like a painting or a sculpture put, okay, this is ideal because we work sometimes in old hospitals that do not have place for this, but we could find ways to insert art in the hospital environment also for the benefit of the patients and of the healthcare professionals. Art as a healing instrument. And I'm going back to psychiatry, it's a recognized tool, the art therapy, for many mental disorders, but it shouldn't be only for them. Anyone having a difficult moment could distress and come back to a better mood by drawing or making paintings or doing any kind of artistic activity. And maybe we're not so talented in drawing, or we don't like to expose ourselves by doing a childish sketch. We can use art as a coping tool by simply visiting museums and art exhibitions for relaxation, and also for improving our observing skills, our interpreting skills, because that might also help us when going back to work and interacting with the actual patient. And this leads us to the preventing level of intervention, because we may help building professional and personal skills through art introduced in the medical students' curricula in the broader area of medical humanities, with the aim of improving empathy, that sense of being part of a group and of a team and interacting, by enhancing observational skills, and also enhancing critical thinking and the idea of working together in the benefit of the patient. Because also, I'm going always back to the first speaker, we must be aware today that none of us knows everything about a patient's condition, because patients most of the time have different medical problems, and we should work together as a team in order to find the best solution for each individual case. And some specific issues regarding burn care staff. Our situation is a little particular because severe burn patients are long-run patients. They have very long hospital stay that may be from weeks to months, and it's a lot of emotional implications from every member of the team. The burn patient is not like any other surgical patients because it's not my patients. It's not one surgeon's patient. It's the whole team's patients. No one doctor could resolve these complicated cases by himself. We really need to be a team, doctors, nurses, physical therapists, psychologists, social worker, a lot of people. And this implies an intense workload, emotional involvement, sometimes physical demand of work, because you have to really be there and support them when trying to moving again and so on, and lack of time for personal activities. Additional factors that might influence quitting the system in burn teams is sometimes inadequate financial compensation, because as a plastic surgeon you could earn a lot more by doing aesthetic surgery. Insufficient resources for patient care, because it's frustrating knowing that you could do this but you don't have it. And lack of public and social recognition and support, because you are being blamed for many things that are not by your mistake, but are misunderstood by the society in general. What keeps us in the game? When we see patients that recover well and go home. This is the most important thing. And for us, working with children, when we see them coming with all those burn injuries as little kids, and we see them after years graduating medical school, well, this is what keeps us in the game. And having the chance of working in this dedicated multidisciplinary teams that understand every step of the work and feel the same and help you when you feel you're going down. What could make things even better is the public support from the authorities and the society, and recognition of the professional value of burn care teams. So, to wrap up, burnout is a problem. We should talk about it, and we should try to do things better in order to keep the staff in the system in a good state, using all kinds of tools that we have, organizational and personal as well, and a good balance between life and work. Thank you very much.
Thank you so much, Dr. Tatar. This is such an interesting topic because burnout is actually a topic that concerns us all in mostly all fields of activity. We overwork ourselves. But in the healthcare system, we do need this professionals to be in their power and to cure patients. And I'm sure that maybe in the EU there are some prevention methods already been, I don't know, taken. But I'm very curious in Romania, in your hospital, have you seen a bit of concern, or how does it work?
No, first of all, it would be necessary to have, for example, a psychologist working in those departments with the biggest pressure. Because you need sometimes to talk to someone
on hand.
That's away from the problem, that can be cold-minded and not so emotionally implicated.
We do not have this psychologist, no?
No, we don't. I heard in some other parts in the country might be, but I'm not sure of that. And it's not a situation really acknowledged as an occupational situation that should be watched, followed, and addressed when problems appear. I know in Germany they have that. They have we do occupational work controls every year, all of us, because it's a legislation. But we don't actually talk to a psychologist. We have to fill just a form, and this should a little be changed, because in other countries they have these talks and were being asked, do you feel that it's a little too much? Would you need counseling? Would you need maybe some time off to get away from that situation?
Have you seen a difference between, let's
say... So
it's
the system. I think everyone is trying to solve things on their own.
Have you seen a difference between, let's say, older generation of doctors and younger generation of doctors in terms of resilience or sensitivity? I mean, is the new generation a bit more exposed to...
I think yes, because they are more individualized, like more isolated in their own, their own sphere of interests, and not quite so open as, and seeing, I may sound idealist, but
we should sometimes be idealists.
If you see medicine just as a job, where you go, you do what you have to do, and you take your salary at the end of the month, I think we have a problem. It should be more, and for many of us, it is more than that. It's not just a job. It's something that we did for a vocation.
Yes.
And really not thinking only of that ending. If you do that, okay, you're more exposed, because the satisfaction that comes from that patient going home, it's not quantifiable.
And this is maybe something that professors, that specialists with a lot of experience should maybe bring towards the younger generation, and maybe...
Probably, and starting from the very early years.
Yes, from the very earliest. Thank you so much for your presentation and for the very interesting topic. So, these were our four speakers, the four presentations. We have come to the last part of this panel, to Q&A. Yes, please.
Dr. Tatar mentioned. I want to share with you a good practice. I visited recently Erasmus Medical Center in Holland, and I saw what you have mentioned. Art in hospital, silent places for patients and for physicians. The community of Rotterdam donated or built it for the patients and doctors a roof garden for keeping them healthy. And I think this kind of models can also be introduced or implemented in our country if we are creating awareness about this subject. And I think we can start a project from here, an awareness campaign regarding the burnout of our healthcare professionals in Romania, and maybe we can invite artists from Romania to donate some of their works to hospitals and create a better place for you as healthcare professionals, but also for your patients. I think we can have a starting point.
This is a nice idea. Thank you.
And I have another question.
Yes, please.
But I like this subject very much. I have a question for you. You said you work with family doctors, and they are afraid to use the new technology. As you know, in Romania, we are facing a crisis regarding the family medical doctors in rural areas, but also we face a crisis regarding the fact that these family doctors are getting older, and we don't have enough young family doctors to, how to say, very keen to go in rural areas. From your interactions with the family doctors, can you say something why they don't want to go in rural areas?
Thank you.
Thank you very much for the question. Two things that I want to mention. First of all, I agree with you, and this is a fact check. All of those doctors that we trained were in rural areas because the project was destined for them. We didn't take a statistic because we didn't ask for their ID cards, but seeing, you can acknowledge the average age. I can tell you that the average age for those participants, 2000 and something we taught, was about 60. Some of them were retired but are going on because they received these 100,000 euros worth of equipment. They want to stay for the duration of the project and then sell their practice. I think we can count on my fingers the young people that were in these rooms, and we were everywhere. We were in Banat, we were in Muntenia, we were in Moldova, Transylvania, Bucharest, not because the procedure was postponed. Why don't they choose it? I think they don't choose it, and young doctors, and we talk to young students and residents, they don't choose it because family doctors, one, are seen, like I said, as a secretary, and this is demeaning. They don't go to the family doctor for treatment. Patients, we go to them to get either a prescription or to get a recommendation to a doctor. And this is bad. And we pushed the family doctors for that because we don't trust their training. We don't trust them to tell us a diagnosis and then say, okay, I don't want a second opinion, I am okay, I go with the treatment that you recommended. Then we all know that in rural areas, the pathology is much more complex. So they are afraid, they don't know who to ask. The pathology, because they don't have access to doctors, they don't have access to the best doctors. We had a discussion with a family doctor and she said, well, we want to do contrast-enhanced ultrasound. That is another type to see if the tumor is malign or benign. And she said, I don't know where to send them even in Bucharest, because I don't know who is doing that in Bucharest. And we said, of course, send them to Cluj. We have these kind of procedures in Cluj in the private area. So I think we have a lot to do. So age, definitely no attraction towards family medicine. The pathology and the fact that you are scared. And to be mean to the doctors also in the room, they are afraid of the risks sometimes. They are afraid of taking chances because they do not get the support from the hospital, from the medical practice where they are if it's a private entity, and they are left on their own if something happens. So then you don't want to be in that position. This is our view on this, and my view also.
Thank you, Dragos. I do know that we have another question from online. Yes, please.
I have a question from our online audience. Given the growing burnout rates among healthcare professionals, just a minute.
Is this the question with given the growing burnout rates among healthcare
what
professionals?
retention policies have proven most effective, and how can they be scaled or adapted across different EU member states?
I suppose we're addressing the question to Dr. Tatar.
I won't be able to answer that because I didn't went with my research on the policy making level. I spoke mainly as a team leader, a clinical team leader, and also as a teacher for medical students.
Thank you. Yeah.
No.
No. No. No. Yes, please. So we have one last question here. Please.
Hello. So actually, I went a little bit through the situations over here. So I was very fortunate to do a PhD in material science, but it was based on cardiovascular, and they were using extensive educational methods in order for the surgeons to do the aortic aneurysm repair, abdominal aortic aneurysm, so the EVAR technique. And then during my PhD, my professor had a burnout. So I had it all with this panel, but my question is, would you consider for the extensive methods also to have the dimension of the research part, because that will be interesting to add to the education, development, technology, but also the research, because we were doing the materials, biomaterials. And then for the burnout, while coming back to Romania, I encountered very often the knowledge or the idea that people were having burnouts, but it was not the same. Because what you have as a personal issue or the difficulties that you have, I don't know, punctual or whatever, it doesn't mean it's a full burnout. Or I know it can be different levels, and this I can understand. The situation that I was in, I was very upset on that person because it was not a burnout. It was an excuse, and that person didn't understand what burnout meant. So how are we dealing with these
things? I think it's, the term is being abused especially in the online environment, because everyone who is stressed, works too much, has other kind of situations, uses this term because it sounds well, and because at least in Romania we started probably after 1990 to like using English terms because they're more fancy. So you don't say I'm tired, I'm in burnout. It's not.
Posh.
What I mentioned, it's a different situation, and it's a combined pressure from the professional environment. And what you said, and probably my colleague also wants to answer, of course, one of the prevention strategies is offering young doctors all kind of challenging opportunities in their working place. Research may be one of them for those who are willing to get involved in this, because not every doctor is interested and able to go for research. There are many surgeons that just want to be surgeons. Not everyone wants to be a researcher, not everyone wants to be a teacher. So it's important, now talking a little about policies, as a leader, to see the potential in every one of the members of your team and try to direct them, to guide them in those points that they may give the best of themselves.
Thank you.
Thank you. It's a very good point, and I believe that, of course, it's very important to have mentors that would be able to protect their time of their trainees for research or training, surgical training, and all the things that they want to address. And here includes, of course, research, but regarding the role of extended reality, what can it be used for? And there are some applications, I'm sorry that I couldn't show them due to time constraints. You can use different methods, whether it comes to meditation techniques that will use such techniques as extended reality, or you can have some supports group. As you said, there's a matter of anonymity, and maybe people wouldn't want to know that they suffer from burnout, so you can create these virtual sessions where everybody is behind one avatar and they can discuss about their shared issue, which is the burnout. So these techniques can be used for medical doctors to prevent this problem.
Thank you. So, thank you. Thank you all once again for these valuable insights, and I do think that we can have a conclusion for today for our workforce development in health, training and retention strategies and policies panel, and that would be that building a strong healthcare system starts with investing in people, in their education, motivation and well-being. And I do think that you can all agree with me on that. So thank you for being here, thank you for your questions, and do stay for the next panel and for the next discussions. Thank you all. Thank you.